Good evening, everyone. Thanks for joining us on this rather sort of autumnal September day. As ever, it's a pleasure to be with you for what I hope will be another sort of engaging and interesting seminar. Thanks so much to Nona and Maz and the whole MPN Voice team for organising and inviting us to talk. And if you're wondering where Professor Claire Harrison is, she's in another meeting at the moment, but hoping to join us towards the end of today's session. So for those of you who don't know me, my name is John Lambert. I'm a haematology consultant at UCLH in London, and I'm also the clinical lead for our MPN service. And I'm joined today by Dr. Liz Kulakov, straight out of the operating theatre. She is a consultant dermatologist at UCLH and a skin cancer expert. So today is a sort of is a little bit sort of out of my comfort zone because we're going to be talking about skin cancer in MPN, and I'm very much not a skin cancer doctor. Dr. Kulakov is, but it's something that I think we've become increasingly aware of in the last probably 5-6 years, as more and more relevant to people who've got myeloproliferative neoplasms. And it's something that I've become interested in and developed a research interest over that period. I think the main thing, or the first thing and the main thing to say about this evening is we're not trying to create any kind of anxiety or worry people. We are going to be talking about different kinds of skin cancers. And we have become aware, and some of you may also be aware, that some people with MPNs are at increased risk of certain kind of skin cancers. Now, the main message is that actually the overall risk is still relatively small. And this is something that's actually been the case for many, many years. So it isn't new. The difference now is we have a much better understanding of the situation. There's lots of new evidence and data, which I'll be presenting a little bit of in my slides, to try to kind of give us a better understanding of how significant a problem is this? Is this a real issue or not? And secondly, and I think most importantly, as we develop new treatments for MPNs, we're starting to get an idea of kind of alternatives and ways to try to reduce the risk, etc. So I think that's probably the most important thing to understand, is that this isn't a huge risk. There's not a kind of a sudden new concern or alert that we're trying to publicize. What we're trying to say is we're much more aware of it now than we were even 5 years ago. And there's lots of things that people can do if they are potentially at higher risk. So this is what we'll be talking about. I'll be talking sort of from the MPN side of things, and then Dr. Kulakov will be talking from the skin cancer side of things, and then I'll be rounding off at the end. Right, so this bit I probably don't need to tell most of you about. These are the 5 commonest myeloproliferative neoplasms, which ET and PV are by far the commonest 2. Myelofibrosis is significantly rarer, and hypereosinophilic syndromes and mastocytosis are much rarer still. So we're primarily talking about the top 3 conditions, ET, PV, and myelofibrosis. We'll be talking about melanoma and also what's sometimes called non-melanoma skin cancers, and that's to say squamous cell and basal cell carcinomas, which are, I say, often put together with the label of non-melanoma skin cancer. And I'll use that term later on. So if I'm talking about non-melanoma skin cancers, it's these 2 together. This is a much rarer entity. I think Liz will probably correct me later on, but I think for overall in the UK, probably the lifetime risk of developing one of these is, I think, is about up to 20%. Is that about right? For non-melanoma skin cancers, and for melanomas, it's up to about 2 or 3%. But one of the things we'll see is that actually that risk varies from person to person. Nothing to do with MPNs, I should add. Just all of us have got that risk, regardless of whether we have an MPN. And there are a number of factors quite separate from the MPN which affect our overall lifetime risk. So these are the conditions we'll be talking about. And these are the kind of the areas we'll be discussing. So first of all, is there a link between MPNs and skin cancer? Well, I've already said yes, there is. And I'll be talking a bit more about what that link is shortly. Are any people with MPN at particularly high risk of skin cancer? Potentially, yes, but again, there's lots of other factors which have nothing to do with MPN, which also increase people's risk factor. And these are certainly things that we could try to modify. That's when Dr. Kulakov will be talking. The second half of the talk was how could I reduce my risk of getting skin cancer, both from primarily from a non-MPN point of view, and what to look out for. What do these skin cancers look like? If I get a new tag or mole or lesion on my skin, when should I ask a doctor to have a look at it? And then finally, it's going to be a section I'll be closing with is if I develop a skin cancer whilst having MPN therapy, what does it mean for my MPN and for the treatment for it? So those are sort of the 5 areas we're going to try to cover in the next probably 45 minutes to an hour. And then we'll have questions at the end of that. We've already been sent quite a few questions, so we'll sort of focus on those initially. And if we've got time for questions subsequently, then please do put questions into the chat, and then we will, if we've got time, go through them one by one at the end. So the first area is there a link between MPN and skin cancer? So this is a Swedish, what's called a cohort study. So the Swedes and the Danes, and to an extent the Norwegians, most of the Nordic countries have got absolutely fabulous healthcare records, much better than anyone else in the world. Essentially, they've got nationwide records of almost every single patient and all their different conditions, blood conditions, heart condition, all the rest of it. And that means that they can then look to see if there's any relationships between one condition and another. And they can do this much quicker and much more power than anyone else can do. So this is a Swedish study. There's a similar Danish study that was published a little bit later. This is from 2018, so 6 years ago this was published. And you can see they use their National Health Registry, and they found just over 9,000 patients with MPNs diagnosed in that 40-year period. So they've been keeping records, what's that, 50 odd years, more than that. And they found another 35,500 people who didn't have an MPN. They then tried to decide, then they looked at the rate of skin cancer, and how many people in this group got skin cancer and how many people got skin cancer in this group, and did the risk seem to be higher in one group or the other? And the answer is yes, it did. So compared with a matched control, so this group here, the people who had an MPN had an increased risk of skin cancer. And in this group, the risk of melanoma was about 1, don't forget that's the top group and that's the very rare kind. That was almost 2 times higher in the MPN group than in the people who don't have MPN. And the risk of getting a non-melanoma skin cancer, so these two here, was about 3 times higher in this group compared to this group. So the bottom line from this very big study was that people who got MPNs seem to have a 2 or 3 times higher risk of getting melanomas and non-melanoma skin cancers. There was a Danish study, as I said, published a year or 2 later, we found a slightly lower risk, but about that. So basically we're talking between 1.5 and 3 times increased risk. So why might this be? What could account for the increased risk of skin cancer overall in a group of people who've got MPN compared to people who don't? So these are kind of the 3 things that when we're coming up with sort of research studies to look at it, we kind of try to sort of postulate and investigate. Firstly, could there be shared risk factors? So could there, for instance, be some genetic mutations that cause both MPNs and skin cancer? We know that, for instance, JAK2 and calreticulin can cause MPNs. Can they cause skin cancer? Well, actually, as far as I'm aware, they don't have any role in skin cancer. What about environmental exposure? Exposure to sun, exposure to smoking, to cigarette smoke. And certainly sun, as we'll see, is a big risk factor for skin cancer, but I don't think it's a risk factor for MPN. And smoking isn't a risk factor for MPN. I'm not sure if it's a risk factor for skin cancer. So I'm not sure about any shared risk factors, but it's possible. What about the MPN itself? Could having an MPN somehow cause changes in the skin that increase the risk of skin cancer. And this is possible. So we know that people who've got myeloproliferative neoplasms tend on average to have a bit more inflammation going on in the body. It's not quite clear why that is, but it seems to be a fairly common finding that there's a bit more chronic inflammation in people who've got myeloproliferative neoplasms. And we know that sometimes chronic inflammation can sometimes cause cancers. It's not a major risk factor, but it can sometimes do that. So that could be a possible cause. Just to be clear, these are not proven things. These are just possibilities, and we'll come back to one or two of them in a bit. The other end of the spectrum, what about immunosuppression? There are some blood cancers which suppress the immune system. And your immune system, one of your immune system's role is to sort of scan your body for cancers. And if it finds a cancer, it's to try to delete it, to try to kill off that cancer before it becomes a problem. But MPNs don't really, unless we stop treatment, and I'll come to that towards the end of my talk, MPNs don't usually cause immunosuppression. So I've got to say, I think these two, there's no real definite link between these possibilities and why people might get a high risk of skin cancer. I think this, just to add, so this was another, I think this was a Swedish study. What it did show actually is that at the time of diagnosis, there's an increased risk of a number of other cancers when people are diagnosed with MPN. So not people who've already been diagnosed, it's actually just before they're diagnosed, in the year or two leading up to their diagnosis, they're at higher risk of being diagnosed with other cancers. And so it might lend a bit of credibility to possibly one of these, that if there is some inflammation, that inflammation does allow other skin cancers to develop. So this one is a possibility, I think. But I think the most likely cause for most people, the link between MPN and skin cancer is probably some of the treatments. And that's what I'm going to focus on now. So just a quick run through what the risk factors as I understand the target. I think Dr. Kulakov will probably go through in a bit more detail, but these are not to do with MPNs. This is just general skin cancer risk factors. So people who've got lighter natural skin color, particularly if it burns or freckles easily, or if people, when they sit in the sun, it becomes very painful very quickly, even if they don't necessarily burn straight away. Blonde or green eyes, blonde or red hair, certain kinds of moles, but particularly history of recurrent sunburn or tanning. So people who, for instance, work out in the fields or out in the open air, particularly in sunny climates, particularly people who go on holiday and kind of regularly get sunburn. I think also sunburn at an early age is a risk factor. And also people who tend to do a lot of sort of sunbed tanning. A family history of skin cancer is a risk factor, and generally, like most cancers, getting older does increase risk. So what are the MPN skin cancer risk factors? So this is the kind of the nub of the question. We talked about what risk factors increase the risk. So what factors in people who've got skin cancer increase what factors in people who've got MPNs increase the risk of skin cancers? And these are the five main areas. So one is older age. Two, and I'll come to this in a second, treatment with hydroxycarbamide. Three, treatment with ruxolitinib. And four, although we hardly ever use this anymore, in fact, almost never, is pipabromin therapy. And there's some studies which suggest that men with MPN are slightly higher risk and may be having PB rather than ET. These are really very tenuous. There's certainly no real evidence for that. But I think, older age, I'm afraid there's nothing any of us can do about getting older. But these are, if you like, the two main factors I want to focus on. Being on hydroxycarbamide is a risk factor for developing skin cancer, and so is ruxolitinib. So, hydroxycarbamide. This is a European study led by Professor Barboui, who some of you may have heard talk. He often comes to patient days. He's a fantastic speaker. And this was an international study, and it basically looked at almost 2,000 people with MPN. And of these 2,000 odd people, about a third had another cancer. and 2/3 didn't. So it's the same kind of thing that we talked about in that Swedish study about 5 minutes ago, but it's looking at slightly different things. So this is all of them got MPN, and it's trying to see if those who developed the skin cancer, developed another cancer, included all cancers, had anything different about them compared to those who didn't develop another cancer. And this is where they found that treatment with hydroxycarbamide, ruxolitinib, pipobroman increased the risk of developing non-melanoma skin cancers. Not melanomas, I should add, just non-melanoma skin cancers. So this is the first clue we've got as to what these extra risk factors are, and particularly it's these two drugs here. Interestingly, interferon, anagrelide, and busulfan, again, quite an old-fashioned drug, but we do sometimes still use this one. But anagrelide and interferon are more commonly used. They do not seem to have or be a risk factor for developing skin cancer. And the other thing to say is the risk seems to be related to length of time after diagnosis and also lengths of time on treatment. So it's not just having, 6 weeks of either of these drugs. It seems to be people who are on it for at least 5 to 10 years. This is kind of the most important study looking at hydroxycarbamide, because this is what we call a systematic review. It's an American review. It looked at studies from across the world, published 3 years ago now, and it looked at all the possible studies and narrowed it down to 10 really good studies, which were looking at the association between non-melanoma skin cancer and what they're called Philadelphia chromosome negative. That's basically all the common MPNs I talked about at the start. And they looked at 10 studies, over 6,000 patients. There's a huge number of patients. And the bottom line was that 8 studies out of the 10 did confirm this link between hydroxycarbamide, hydroxyurea, and non-melanoma skin cancers, and 2 didn't. So overall, their view is that there is a relationship between hydroxycarbamide and non-melanoma skin cancers. How might it do this? Now, we've got a drug which we think just focuses on the bone marrow, on the blood, and the whole point of hydroxycarbamide is it slows down the rate of blood cell production. It effectively it slows down the rate of DNA synthesis in the bone marrow cells. How on earth does that increase the risk of skin cancer? I'm going to try to explain this in this slide. So this is a very long name, ribonucleotide reductase, and this is a chemical, an enzyme that helps make DNA, and it in particular helps make the DNA that your blood cells need to make bone marrow, that your bone marrow needs to make blood cells. So what we try to do with hydroxycarbamide is we block this enzyme. If we block this enzyme, it stops the bone marrow cells making blood cells. It slows down the production of platelets. It slows down the production of red cells. And that then means that basically people's blood counts drop. And that's exactly what you want for most people with ET or PV, for instance. So that's a good thing. By inactivating this enzyme, it slows down red cell or platelet production. However, another function of this enzyme is it repairs damaged DNA across the whole human body. So, for instance, in the skin, it was what we were interested in. So the whole point of this enzyme is it protects your cells, because DNA damage, if it doesn't kind of get corrected, can eventually lead to cancers. That's actually, these are mutations we're talking about. So let's say something's causing mutations in the skin, and what commonly causes that is UV light, so sunlight. You need this enzyme to help repair the DNA to protect your cells from that damage that's done. Because if you don't do that, then that increases the risk of cancer in years to come. So if you block that enzyme, because that's what we want to do it here, then that increases the risk of cell damage, and eventually it reduces the skin cell's ability to repair the DNA damage due to UV light. Just to put that into a little sort of diagram, this is a UV light from the sun. This is what causes the damage to the skin. I think it's skin aging generally, but also increases the risk of skin cancer. And normally what would happen, if there's only a bit of damage, then your body could repair it. Obviously, if there's a lot, that can lead to skin cancer. So that's why people who burn a lot, who get lots of sunburn, increase risk of skin cancer. But what hydroxycarbamide does is it inhibits your body's ability to protect itself, to repair itself. And that leads to mutations appearing in the DNA, which eventually, over many years, can result in skin cancer. So that is how we think hydroxycarbamide slightly increases risk of skin cancer, particularly in people who've got a lot of UV skin exposure, UV light exposure. So that's hydroxycarbamide. We know it does seem to increase the risk, probably doubles the risk. I would say in ballpark figures, and it does that because it stops the skin cell's ability to repair the damage done by UV light. What about ruxolitinib? This is a much newer kind of, well, it's a much newer entry into the kind of treatment, because we've had hydroxycarbamide for what, 40 odd years, certainly more than 30 years. Ruxolitinib we've had for about 12 years, probably less than that. But there is increasing evidence it does also increase the risk of skin cancers, probably or possibly in a different way. So this is a really important COMFORT-2 study. This was a study that you may recognize some of the authors, and it showed sort of for the first time how really effective ruxolitinib it is. So it was a randomized study comparing ruxolitinib with old-fashioned treatments, basically what was called best available therapy, which some of that would have been interferon, some of that would have been thalidomide. There's a whole range of different things. And this was a study that showed that ruxolitinib is much better than any of the old treatments in terms of shrinking people's spleens, making people feel better. In the longer term as well, it can sometimes push down JAK2 levels, and sometimes in a proportion of people actually can make them live longer as well. So that's an important thing just to remember before we talk about the side effects of ruxolitinib, is quite how effective it is in treating myelofibrosis. But they also, as part of that, they have to look at side effects. So one of the side effects that became clear during the follow-up from the study was that the rate of these non-melanoma skin cancers, so these are the squamous cell and the basal cell carcinomas, the rate of skin cancers was about double in the ruxolitinib treated patients compared to those who got the best available therapy, BAT. These are the patients who got the old-fashioned therapies. So these people had much poorer outcomes in terms of their myelofibrosis was much poorer treated, but their risk of developing a non-melanoma skin cancer was about half that of the ruxolitinib treated patients. So again, a suggestion from this study that ruxolitinib roughly doubles the rate of non-melanoma skin cancers. And there's been a few other studies which have shown a sort of similar kind of thing. Last year, in fact, earlier this year, a group of us from the UK, and you may again recognise a number of the authors from the big UK centres, tried to collect together all of the patients that we're aware of who have been treated with ruxolitinib and have developed skin cancers. So across the UK, we've probably got over 1,000 people on ruxolitinib. There's lots and lots of patients on ruxolitinib. And of all the patients we have across the country, we could find 90 who had developed skin cancers. And I'm not going to go into what we did. I'm not going to go through this in great detail, but we looked at how many continued on the same dose of ruxolitinib, how many had a reduced dose, how many stopped it, and how many switched to something else. And most of the time when this study was being done, there weren't really any alternatives. So one switched to thalidomide, one switched to fedratinib, and two switched to interferon. And what we did is we looked to see, what happened to people who had skin cancer whilst on ruxolitinib. And first of all, we found that the commonest skin cancer was squamous cell carcinoma. That's a non-melanoma skin cancer. What was interesting is you can see that out of that, you probably can't read it, but out of the 90 people who were treated, 62 continued on the same dose of ruxolitinib, and 9 stayed at a reduced dose. So basically 71 out of the 90 patients stayed on ruxolitinib. One of the findings that we're not sure of, but we're seeing, we're suspicious that some of these cancers, so usually squamous cell and basal cell carcinomas, these non-melanoma skin cancers, tend to behave quite indolently, quite sort of quietly, and often they can be cut out and they don't come back. They wouldn't usually be expected to affect people's quality of life or affect their life expectancy or etc. So what we did seem to see a slight trend for was that some of these, particularly some of the squamous cell carcinomas, did seem to be more difficult to treat than we'd expect in patients who weren't on ruxolitinib. And the main conclusions that we came to was that, first of all, everybody, doctors, clinical and specialists, patients, pharmacists, everyone should be aware that ruxolitinib does increase the risk of skin cancer, probably doubles it. And that risk should be discussed with patients when we start people on it. And in particular, it's really useful for patients to tell us if they've ever had skin cancers before, or if there's a strong family history of skin cancer, or if they've worked outside, if they happen to work out, I know, in Australia, out in the sort of the sun for 20 years of their life. Because people like that, their background risk of skin cancer is higher than average. And those are the people we particularly want to watch out for if we start them on ruxolitinib. It would not be a reason to withhold ruxolitinib, but we need to be particularly mindful of people who've got a high risk because of their family history, or they've worked in this in sunny areas, that kind of thing. And the other big message was that patients taking ruxolitinib and the doctors looking after them should keep an eye out for skin cancers and report them promptly if they're worried about that. And that's what Liz is going to be talking about very shortly. So we've explored how hydroxycarbamide could increase the risk of skin cancer. We said it's related to it affecting the body or the skin's ability to protect itself from UV sun damage. What about ruxolitinib? Well, we don't know. And this is a really interesting point of research right now. How could this new drug, ruxolitinib, it works a completely different way compared to hydroxycarbamide. It doesn't interfere with that enzyme I talked about. How could it increase the risk of non-melanoma skin cancers to about the same extent as hydroxycarbamide? So could it impair DNA repair like hydroxycarbamide does? Could it affect cells' ability to protect themselves from the sun? We don't know. Or does it suppress our immune system? You remember I mentioned about 10, 15 minutes ago that if someone's got an impaired immune system, particularly if it's very suppressed, for instance, people who had heart transplants or liver transplants for the rest of their life have to take very strong immunosuppressants. And people in that situation do have a higher risk of certain cancers, including skin cancers. So do we think ruxolitinib could do that? We do know that ruxolitinib is sort of moderately immunosuppressive. It does suppress the body's immune system, particularly, say, our T cells. And so could it be that actually it's not that it's affecting DNA repair, it's interfering with the body's ability to search for cancers and kill them off when it finds them? It's a subtly different thing, or it could be both. We don't know. And this is something, so this is a shameless plug for Mithridate. So this is a study for, it's an academic study across the UK for people who've got PV. And it's basically comparing ruxolitinib with alternative treatments like hydroxycarbamide or interferon. But we're planning in the next few months to add on a sort of a side study to it to look for people, anyone who develops skin cancer whilst on the study. We'll look at the genetics of the skin cancer and see if it looks anything like the MPN. And we'll also be doing little mini skin biopsies to see what happens to the genetics of the skin. So we're still setting that bit of the Mithridate. So Mithridate itself has been running now for quite some time, but we're hoping in the next 6 months or so to open the second part of the study to look at the relationship between ruxolitinib and skin cancer. So watch this space, or watch MPN Voice, because it'd be really interesting. And then this, I think, is probably the most important bit of the talk, is how can I reduce the risk of getting skin cancer? And what should I look out for? So I'm going to hand over to Dr. Kulakov for this, because she is the absolute expert. She's worked with us in these studies that we've been doing to look at MPNs and skin cancers.
So thank you so much for inviting me today. And also thank you very much to everyone for dialing in and staying for this. So I was going to talk quite briefly about the importance of skin health in MPN care, and talk a little bit about daily skin protection, and also then going on to talk about self-monitoring and the importance of that and what you should be doing. I'll briefly cover what you should do if you are at all concerned, and then a summary of common type of skin changes and what to look out for. As John had said, talking about the non-melanoma skin cancers, and also briefly about melanoma skin cancers. Skin is the largest organ in the body, and skin problems in the general population are extremely, extremely common. Some figures that are around say that as many as 40% of all GP consultations are something to do with the skin. Skin cancer as well is incredibly common in the general population. And as John had said, that the risks are approximately 1 in 4 in men and slightly lower 1 in 5 in women of developing some kind of skin cancer over the whole lifetime. We also know that the rates are rising. The risk is increased in immune compromise, and that can be from either a disease process or treatment, as John had been talking about. And the main message of my talk, I think, is the fact that the majority of skin cancers are preventable, and a lot are treated very easily if they are caught early enough. So skin cancer prevention starts at birth. We know that ultraviolet light radiation coming from the sun is a major cause of skin cancer. The skin damage that it causes tends to build up gradually over time. And so the sun damage that people are seeing on their skin when in their 50s, 60s, and older will have started from the time that they were young children. This is a photograph of an American long-distance truck driver who was sun exposed on one side of his face and not the other through his occupation. And you can see very clearly the causes, the effects of ultraviolet light radiation on his face. It causes things like wrinkles, uneven pigmentation, loss of elasticity, blood vessel changes, but also skin cancer risk is increased. So all of us can modify our behaviors to try and decrease risk of skin cancers. And the main thing is that we want to do this whilst continuing to lead a full, healthy, and enjoyable lifestyle. So sun protection starts mainly with covering up and seeking shade and staying out of the sun. Consider also sun protection factor clothing, which has got a very thick weave. Wearing hats, wearing sunglasses is very, very important. And then, as you've probably heard, the general advice is to avoid intense sun exposure, which tends to be between 11 a.m. and 3 p.m. Another important part of sun protection is using sun creams. The aim of this slide is definitely not to promote any of the sunscreens that I've pictured, and to say that the main thing is that you pick high factor sun cream, which tends to be SPF 30 or above, and also choose a high ultraviolet A rating. And this tends to be found separate to the SPF, and it is a circular logo with some stars in it. And you want to be looking for things that have at least 4 stars within them. All sunscreens that are marketed as SPF in the UK have gone through a very good testing process. And so irrespective of whether you buy it for £2.99 from somewhere like Lidl or Aldi, or whether you spend £60 in Harrods, the SPF protection factor should be the same. However, the more expensive sun creams might feel slightly nicer on the skin. And my advice is to apply the sun cream daily to all exposed skin, approximately 20 minutes before going out. You want to try using it instead of face cream, and then additionally apply it to other exposed areas such as arms and neck, especially if you're going to be going outside a lot. The advice is to reapply after sport if you're going to be sweating a lot or swimming, as the sunscreen will rub off. And the other important point to mention is that you want to be using sufficient amount, so approximately 1 shot glass full for an entire body, and obviously a lot smaller amounts if you're just applying it to the face and neck. Some people have asked whether chemical or physical sunscreens are more important or better. There is no answer to that. They offer quite different types of protection in the sense that chemical sunscreens tend to be more cosmetically acceptable and then tend to be transparent, and physical sun cream tends to be more white in color, but is much better for skins that are prone to allergic reactions. So once you've developed behaviors that minimize sun exposure, you want to focus on self-monitoring. The idea is to take time out and stand in front of a mirror, unclothed, and look at your skin all over. And you want to develop a habit of doing this regularly. How frequently this is done differs, the advice differs. So Melanoma UK website advises that you examine your skin once a month. Other physicians say slightly less frequently, maybe every 3 months or so. You probably will have heard about the ABCDE algorithm. This is only used for moles, and I'm going to cover it briefly a little bit later on. But you also want to record all your other spots that you might be noticing or concerned about. You can use a smartphone to take a photograph, or there are other apps available. And once you're used to doing this, it should only take approximately 10 minutes. And I think the main message is, if you're at all concerned about any change, you should seek your GP. You should seek the advice of your GP. They would much rather reassure you with a spot that is not worrying. It is perfectly normal to get new freckles, patches of discoloration, or various lumps and bumps over time. The majority of these are probably not concerning, but any new lesion, especially in people with MPN or other immunosuppression, should be checked. Typically, the things that we are looking out for are any new moles, any persistent scaly red patches, any non-healing or scabbing areas, and also things like new lumps, bumps, or any painful areas of skin. So if you have something that you're concerned about, you should see your GP in the first instance. I would suggest that typically within about a fortnight would be preferable. Your GP should ask you a brief history and then examine your skin just by looking. Some doctors may use a piece of equipment called a dermatoscope, which has a magnifying glass and a bright light. And then from then on, a number of things might happen. If they are not concerned about these skin changes, they will reassure you, and they should advise you to continue monitoring your skin. If they're at all unsure, they may send a photograph to a dermatologist and the service is known as teledermatology, and then they should get a reply within approximately a fortnight. And then if there's greater level of uncertainty or concern, they may refer you to the hospital via what was previously known as the 2-week wait rule. And from there on, you should receive a dermatology appointment within approximately a fortnight. So at the hospital, it will be a very busy clinic in an outpatient department, and you may be seen by a variety of healthcare professionals. These tend to be either dermatology registrars, clinical nurse specialists, or consultant dermatologists. They will again ask you a brief history, and at this point, it's very important to mention MPN and also any current or previous treatments that you've had for this. As John was mentioning, the skin cancer link between ruxolitinib and any skin changes is not yet very well known, so do make the doctor aware of this. You will be examined and definitely be prepared to be offered a full skin check, which means that the doctor will ask you to take your clothes off down to underwear, and they look at your skin all over. And from then on, they may recommend either a biopsy or complete removal of the lesion, or they may simply reassure you. As John had covered already, there are basically 2 broad categories of precancer and cancerous changes. And these are non-melanoma skin cancers and melanoma skin cancers. Probably the most common changes are actinic keratoses. These are also known as sun damage or solar keratoses, and they typically arise as flat, scaly, and either pink or red patches on sun-exposed areas. So classically, this is the face, the scalp, the arms, the hands. And these are early precancerous changes. They're incredibly common, and there is a small risk of them going on to become squamous cell carcinomas. The risk of individual actinic keratoses becoming SCCs is low, but the more AKs that a person has, the greater their risk developing SCC in the future. There are lots and lots of various treatments for actinic keratoses. They typically involve either using a cream or having some kind of light treatment called photodynamic therapy, and they can be incredibly helpful, and they will also decrease the risk of SCC formation. So squamous cell carcinoma is a very common type of skin cancer, which is more common in people with immunosuppression and with MPN. It is an invasive skin malignancy, and it presents as a pink, red, or flesh-colored bump on the skin, typically with a crust, and it can also be painful. It can grow quite suddenly, and appears seemingly out of nowhere. It is invasive, but it is typically easily treated with either surgery or radiotherapy. It does have the possibility of spread, so it's very, very important to pick up SCCs as early as possible. And the typical survival rates of people with squamous cell carcinomas are 99% at 5 years if they are picked up early. Basal cell carcinomas are the most common form of skin cancers. They're very slow growing, They do not spread and typically do not cause any problems with the person's general health. They present as a pearly or flesh-colored bump, again, most commonly on sun-exposed areas. They can also present as flat, red, scaly patches. And there are lots of very successful treatments. And the earlier they're caught, the easier those treatments tend to be. So surgery can be offered, radiotherapy can be done, and in some specific cases, they can even be treated with creams. And then lastly, melanoma. So this is the most, this is potentially the most serious skin cancer, but is also one that is the rarest. And to try and pick up melanoma and to teach people how to examine their own skin, then there are these rules called A, B, C, D, E rules for melanoma. And these are dark-colored patches on the skin or moles that show asymmetry. So if in your mind's eye you cut the mole in half, one half should look similar to the other. And if it's asymmetrical, then it should be checked out. Irregular borders, irregular color, and larger diameter. So typically those are patches of diameter of 7 millimeters or larger. And then the most important letter of them all is E, which is evolution or change over time. So if any patch changes over time, then it should be looked at by a doctor. And so what you are looking out for on your skin is either a long-standing mole, which is changing gradually in shape, color, or size, any new mole, or any sunspot, which is also evolving and changing shape and appearance. The main thing is, don't forget the harder to see areas, such as the ears or the back, or long-standing patches that you may not have even noticed change. And the main thing is, don't worry about bothering your doctor for nothing, because it's much, much better to be checked out and be told that there is nothing to worry about. The other good idea is to take photos to track changes over time. So melanoma, which is the least common but the most serious skin cancer, can spread. It can affect your general health and it can cause death. Most melanomas are caught very early and are treated very successfully by removal. So over 90% of melanomas are either stage 1 or 2 at diagnosis, and they have very good survival rates. There are very many new effective treatments for later stage disease as well. But the key message is that early detection is vital. So thank you very much for listening. And in summary, I want to say that you can definitely take many positive steps to decrease your chances of developing skin cancer. Regular monitoring of your skin is very important. And if you have any concerns, you should ask your doctor or a specialist nurse for advice. Thank you very much.
Wow, I wish we could do a proper clap. That was amazing. I really enjoyed that.
That was brilliant. I've just got a few more slides, Claire.
Perfect.
And I've just got a couple more slides, I think, just to kind of finish off on what to do if you are diagnosed with skin cancer whilst on treatment. If I develop skin cancer whilst being treated, what does this mean for my treatment? So the first thing, I think the most important thing, is that if you are diagnosed, please let your MPN doctor or CNS know that you've been diagnosed, because the MPN doctor will usually want to have a conversation with the skin cancer doctor to find out how serious it is, whether it needs any treatment, whether it's something that's very straightforward that just needs a very minor surgery to remove it, or whether it's something that's a bit more serious. Ask your skin cancer doctor to liaise with your haematologist, so make sure the conversation goes both ways. Often they're not in the same hospital, so sometimes people have to have conversations with doctors they may not work with every day, but I think it's really important to try to build up those links. And then have that conversation once kind of it's become clear what the skin cancer treatment is, what the longer term implications are. Then have the conversation with your MPN doctor about whether you need to change your MPN therapy. And as we talked about earlier, actually for lots and lots of people, they will not need to change their treatment. Their current treatment will be the right treatment still. And certainly for most of the patients in my clinic who I see who develop skin cancer, I will recommend they stay on the same treatment. But the questions to ask are, what MPN therapy you're taking, or are there any equally effective alternatives with a lower risk of skin cancer? Now, in many cases, that's very difficult to establish, but it's certainly something that we should be talking about. How serious the skin cancer is, we've just mentioned that. Is it something that can be rapidly removed, or is it something that's going to have longer term implications? If this is a recurrence, then usually that'll be more serious, not always, but usually be more serious compared to this first episode. And also what your views are. How much benefit are you getting from your ruxolitinib, for instance? Generally, most of the patients I speak to who are on ruxolitinib, they're so much better on it compared to before they started taking it, that actually stopping it is really just not a viable alternative, not a viable proposition for most people. So, I think we absolutely have to take into account what your views are. In the interest of time, I won't dwell on this, but this is just to say that people have looked for skin cancers with other JAK inhibitors. So ruxolitinib is the one we've talked about, and these are the three main studies. And you can see that all three studies did talk about skin cancers in that. Fedratinib, which is available in the NHS as sort of second-line treatment, the two main papers didn't talk about skin cancers. Pacritinib, which isn't available in the UK at the moment, but is, say, in the United States, one of the studies did talk about skin cancers. And to my knowledge, momelotinib, Claire may have more up-to-date data, but I'm not aware of any skin cancers reported for momelotinib. Tofacitinib is one that's used, I think, more by rheumatologists, but it's another JAK inhibitor. So in terms of, these are the sort of the four JAK inhibitors in general use, although pacritinib is not available in the UK. This is ruxolitinib, fedratinib, pacritinib, and momelotinib, the newest sort of kid on the block. And certainly there is a suggestion, as we've talked about, that there's evidence that ruxolitinib does increase the risk of skin cancer. Pacritinib maybe, as we saw, but as far as I'm aware, there isn't any clear evidence for fedratinib or momelotinib. It may be just that the data isn't mature enough. We haven't got enough follow-up yet. So I think it's premature to say that these are safer than ruxolitinib, or that if someone develops skin cancer on ruxolitinib, we should switch to one of the other alternatives. But it is part of the discussion. That's we've already talked about. And the bottom point, I think, is the most important one. For many patients, the best approach is to remain on their current therapy, to reduce other risk factors for skin cancer, so particularly sun exposure, and be vigilant for skin cancers in the way that Liz has so brilliantly demonstrated. So this is my final slide. So some people with MPNs are at increased risk of skin cancer. It isn't a huge risk, but it's important to be aware of it. We think the risk is mainly related to therapy, hydroxycarbamide and ruxolitinib being the two drugs we're most kind of conscious of. People taking these two drugs should be aware of the risks. They should ensure that their MPN doctor knows of any skin cancer risk factors, such as if they've had a skin cancer before. And most importantly, take steps to minimize other skin cancer risks. If you develop a new skin lesion, report it promptly to your MPN doctor as well as your GP. And certainly if it does turn out to be a skin cancer, then let your MPN doctor know straight away. And then if you're diagnosed, you need to have that discussion about whether to consider changing treatment, but we don't know really, certainly if any of the other JAK inhibitors are definitely safer, We think that, for instance, interferon may be safer than hydroxycarbamide in that instance, but for many people, the side effects of interferon otherwise may outweigh the potential benefits. So it's very much a dynamic discussion, a dialogue, rather than being sort of one size fits all. So I think that is the last slide. It is. So with that, I will now hand back to Claire, who's going to chair the rest of the discussion. Thank you, Claire.
Excellent. And those were really important slides, actually, because they really helped us to kind of bring back to focus on that. I just want to thank you both for such a really, really informative couple of talks. As we already said, I've learned a lot. Now, we did have a question in the chat, which actually I think you've already answered, John, with regard to momelotinib. So you've answered the question about JAK inhibitors, but my view, and I'm interested in your view, is that it's probably what we would call a class effect. So I don't think you could definitely move between JAK inhibitors and think it's going to have a different effect on your risk of skin cancer. And one of the reasons we don't know as much about these other drugs is they haven't been around as long, and we haven't got such comprehensive sort of follow-up. But John, I think you covered that, but did you want to just comment on it?
No, I think that's exactly the point, that we don't know. That I think over time we'll probably get more information, and hopefully in a few years' time we might be able to sort of give a bit more sort of informed kind of views. I'm sure there is a class effect, and I'm sure that all of them potentially, I wonder whether there's some immunosuppressive effect from all of these drugs, and that's how they're doing it. But it may be a bit more for one, a bit less for the others. So only time will tell whether they're all equivalent or whether some are higher risk and some are lower risk. But I think there'll be a degree of risk with all of them.
And there isn't really a test that we can do to say that, one is better than the other, because we don't really know what the cause is. So, Liz, actually, and thanks everyone for pre-submitting your questions, but if you do want to put a question in the chat, you're really welcome to. There's a few questions actually about other skin changes with hydroxycarbamide that have been submitted. So there's one about nail markings and one about red blotches and petechial-like, that's red blotches, isn't it? Sort of rashes. Did you want to just comment on other kind of skin effects of hydroxycarbamide, maybe?
So I think the main thing to say is to make sure that your doctor who's prescribing it is aware of these changes, so that they can be looked at more individually. But certainly, yes, it can cause, I think somebody mentioned itching, and yes, it can cause red blotches and nail markings. Yes, but equally, you wouldn't want to just put it down to that. So it would need to be looked at on a case-by-case basis.
And particularly something that hydroxycarbamide can do is that it can cause pigmentary changes in nails as well. So, okay. Very good. John, did you want to pick out a question that you fancied answering, or yourself? Liz, we've got a little spreadsheet we've been looking at between us, you see. Anyone that springs to mind? Maybe you first, John.
Thanks. I'm just looking down the questions to see which ones we sort of haven't answered yet. I think
while you're looking, I'll answer Mary Green, who's put a question in the chat. Hi, Mary. About clopidogrel. So any drug can cause a rash. Clopidogrel, not particularly, but any drugs that can affect clotting, like clopidogrel, like aspirin, like warfarin, or some of the newer anti-clotting drugs like apixaban or rivaroxaban, they can all cause bruising and increase in bruising, but not aware of any particular kind of skin cancer risk as such with clopidogrel. But good question. John, did you spot anything you wanted to?
Yes. So I think there's a really interesting question about how skin is affected by MPN's driver genes, because we know that sort of some cancers are caused or at least increase the risk of by certain genes. And we know that MPNs in particular, and some people's MPN, if like, is caused, we think, by JAK2 mutations of calreticulin, but there's other mutations that can contribute to that. I think that's a really interesting question. There's no obvious correlation, so there isn't a definite gene that causes both. But that's exactly, remember I talked about that mithridate sub-study that we're hoping to get set up. That's exactly what we're going to be looking at. We're going to be, as I said, taking skin biopsies from people before they start on ruxolitinib and afterwards, and seeing if there's any genetic mutations at the beginning and genetic mutations at the end. No one else has done that. And I think it's a really fascinating question. So the bottom line is we don't know of any common mutations, but it's very much uncharted territory.
Right. So Liz, I've picked one out for you, but feel free to answer this one and then I'll answer one that's one of your favourites. You gave us really clear advice on sun cream, which I was hastily noting, and I'll be watching that back and checking a shot glass, etc. Really good. There is a question about sun cream reducing actinic keratosis, because we talk a lot about sun cream and thinking about skin cancer, but of course actinic keratosis is very common, as you said.
Yes. So actinic keratoses can actually be dynamic changes in themselves. So they can come and go. Typically, if you have a lot of actinic keratoses, you're not expecting them to resolve completely. But certainly using sun cream can help in both reduce the actinic keratosis load and also prevent them developing further ones as well. So I would definitely say if you have actinic keratoses, use sun cream and don't think that, well, I've got sun damage, so there's no point anyway. So yes, sun cream can help reduce actinic keratoses.
And then I'll ask the one about tattoos in a minute, but there's a great question as well about taking hydroxyurea or hydroxycarbamide, same thing, traveling abroad for a holiday. Can I not sit in the sun at all, even with factor 50? Sunglasses don't protect you from skin cancer, so you do need to put the sun stuff underneath the sunglasses, and a hat. I think you're probably going to talk about time of day, etc.
But also, I think what is important to realize is sun cream is not a complete sun block. So when you look at SPF, I don't want to get into too much detail, but sun protection factor will increase the time that you can spend in the sun without burning. So, for example, if you sit outside in sunlight and it takes you 10 minutes to become pink and for your skin to tingle, then an SPF cream of 50 will increase that time 50 times. So it will take you much longer to become pink and burn, but it does not completely prevent the UV rays from getting through to your skin. I would say that if you already have a degree of predisposition to skin cancer and a risk of it, I would probably try and relax on holiday in a different way than sitting in the sun. Not wanting to be a killjoy, but that would be my advice.
But you could still do some travelling around with a long sleeve top on and a sun hat.
Absolutely.
It's just lying in the sun and roasting.
Absolutely. And I think the other thing that's very important is activities like playing tennis or going outside on a hike. Doing something active is so incredibly important for other things like your cardiovascular health, your mental health, that you should definitely not stop doing any of those. But I'm a bit wary of saying that it's okay to lie in the sun despite all of the protection methods that you might use.
I think probably you wouldn't be lying out in the sun as a dermatologist. I mean, all the dermatologists I know give very sensible advice and say don't lie out in the sun, even if they're not a patient taking a drug that might increase their risk of skin cancer.
Yeah.
Okay. I'm going to take a question about whether patients on hydroxycarbamide should have routine dermatology appointments or only when they have new skin lesions or skin changes. Because I think there's a kind of element here about what is platinum and amazing healthcare, and also what is really feasible. So, I mean, I think it would be absolutely great if we could see it, if all my patients on hydroxycarbamide or ruxolitinib could see a dermatologist. But in actual fact, if they did, and they can't, they probably would need to see them on the 5th day after they've just had an appointment that's a once-a-year appointment. So I think the way that we organise our services is rapid access, as Liz had said, if you've got a new change, and you'll find that there is speedy access. And then once you actually have been into the service, and you have been seen, if you have had a skin cancer or a pre-cancer, you probably would go on to some sort of enhanced observation. So there are other things that are also important as a patient anyway, of course, and looking after your skin is just as important, but things like blood pressure, exercise, etc. So we've had some great tips today for how to screen your skin and when to go and have some questions and have a review. Now, I'm just going to ask you, Liz, then about, could you answer 2 questions that have come in the chat, please, about two slightly different. Well, one's a question and one's a comment. One's about tattoos, and the other one is about, I think, the melanoma.
I think
and
John
you can answer the
said
one. John, you want to answer that one? Yeah.
So tattoos, I mean, it's difficult. So you kind of have to examine for any changes, and you have to kind of try and look through the pigment of the tattoo, but it definitely makes it more challenging. Definitely when patients come and they have skin changes within the tattoo, you will probably have a slightly higher, lower threshold for either doing a biopsy or removing a lesion to make sure that it's not concerning. But I think, you know, you will know what your skin will look like, and so any changes should be reported. And then there's another comment about using umbrellas in the sun. No, definitely a great idea. I don't think you're kidding yourself at all. I think an umbrella, whatever color it is, will offer shade and is definitely something to be encouraged.
Great. And then John, we obviously can't comment on a specific patient's case, but I think it would be good if you could just comment on sort of melanomas and maybe ruxolitinib in general. Thank you.
Yeah, definitely. And I think, you know, we've had a couple of sort of general questions about what to do about melanomas or indeed non-melanoma skin cancers. So, as I said, I think the broad point is that not to make any sudden changes, to discuss it and to make sure that there's been a conversation between your haematologist and your dermatologist or whoever's managing the skin cancer. Because as I've learned, and I've kind of become interested, as I said, over the last 4 or 5 years, not all skin cancers are the same. Not all patients are the same. And so you have to know for that individual patient, what kind of skin cancer it is, how sort of serious it is, how much treatment it's going to need before making any judgments. And that's something you need to find out really from the dermatologist. And secondly, you need to know as a haematologist how much benefit that patient's getting from the drug they're on. And like I said, lots of patients get a huge amount of benefit from, let's say, their ruxolitinib in terms of controlling their symptoms, shrinking their spleen. And like I said, in some people, it can also extend their life expectancy. So it's a really important drug. Equally, hydroxycarbamide is really important at controlling people's blood counts and reducing the risk of blood clots, heart attacks and things. So it is really trying to work out for the individual person, what are the risks of changing that drug or stopping that drug compared to the risks of carrying on. And that's a very individualized judgment based on the skin cancer and the benefits they're getting. But my experience has been that for most people, I've tended to keep people on it. I have tried to stop people in a couple of occasions if they've had skin cancers that sort of seem to be particularly serious or particularly keep coming back. Particularly with ruxolitinib, I've often found that when you try to stop it, patients feel so rotten when you've stopped it, they end up wanting to go back on it, and we then have the conversation about whether we try to reduce their dose, but we don't know whether that makes any difference. So it is a very individualized decision. There isn't a one size fits all.
Okay, absolutely great. I just want to again thank you, Liz, and thank you, John, as well as thank all of you for being here, listening. It's clearly really, really important subject, both for kind of general health as well as especially for MPN patients, as we've heard. Super informative. Thanks also to Charlie for operating the webinar this evening. Apologies, I gather there were a few little technical issues as we started. Can't always help those, and sorry that I wasn't here at the beginning. So I think I'm going to hand over now to Debbie, who's going to close, and Charlie, you're going to put a slide up for us. Thank you so much.
Okay, thank you very much indeed, Claire. And again, thank you to everyone. Absolutely wonderful presentations, great questions and panel answers. Nona, before the technicals actually started, was just talking about tomorrow being the MPN Awareness Day. So a very special day for us all. At MPN Voice, we're able to put on these presentations for you and these forums virtually. We would be very, very grateful for any additional support and help that you could give us. Any donation of any amount would be very, very gratefully received. So thank you all again for your wonderful, wonderful support. Have a lovely evening. Thank you very much and good night.